Hi, my name is Traci Hewett, and I'm going to be giving a short presentation about physician-assisted suicide and answering questions directly afterwards. There's been much debate over physician-assisted suicide. Physician-assisted suicide occurs when a physician either prescribes or injects a medication with the express purpose of causing death. A concern is that most patients are unaware that they have other options available to them. Hospice and palliative care services are available for patients who are both terminally and chronically ill. Hospice care services are for patients who have documentation from their physician that they're both terminally ill and they have less than 6 months to live. Palliative care services are very similar to hospice care services. They're just expanded to include chronically ill patients. I'm a paramedic, and in considering the lack of knowledge that most patients have concerning palliative care and hospice services, I'm reminded of a patient that I was transporting to dialysis. Dialysis is a procedure that patients have to go through when they've lost most or all of their kidney functions in order to survive. Most dialysis patients die within 7 to 8 days after stopping dialysis. On the way to the clinic, the patient pretty much implied that he was done with dialysis. He didn't want to go anymore. He just wanted to be left alone. This was a very intelligent man who was completely unaware that it was his basic right to refuse to continue in dialysis and instead be referred over to palliative care and hospice so they could effectively manage his pain. New research suggests that physicians need to know when to stop life-saving treatments and instead refer patients over to hospice care where they can receive end-of-life services and counseling. Physicians need to make sure that hospice and palliative services are offered very early in patients' end-of-life care and that they are thoroughly explained. Physician-assisted suicide should never be considered until hospice and palliative care are adequately explained and offered to chronically and terminally ill patients. Research suggests that underutilization of hospice care stems from a combination of a physician's lack of knowledge about hospice and their inability to effectively communicate between patients and their family members. Research completed by Kaiser Permanente Medical Centers revealed that 78% of the physicians they interviewed felt that hospice was underutilized. 84% of these physicians could not adequately identify the diagnoses that make hospice available to patients. Kaiser research also cited that these same physicians were limited in offering services due to having difficulty talking to their patients about end-of-life services, or because they feared that patients would view their referring them to hospice as them giving up hope on them. Studies done by Yale University shows that many physicians are unable to effectively convey the severity of the patient's illness. The graph was made using the data from that Yale University research. The graph represents when patients and their families were first told that their illness was incurable and when the patient was referred to hospice care. The red column represents when the patient was advised that their illness was incurable. As you can see, 32.4% of patients were aware that their illness was incurable more than 6 months prior to their death. 41.1% of patients were notified from 1 to 6 months prior to their death, and 23.5% knew less than a month before they died. The blue column represents when patients were referred to hospice care. 8.9% of patients were referred more than 6 months prior to their death. 50% were referred from 1 to 6 months prior to their deaths, and 41.1% were referred less than 1 month before they passed away. What this information shows is that only a small percentage of patients are told about hospice more than 6 months prior to their death, and although 50% of patients are told in between 1 to 6 months, almost half of the patients are only referred to hospice care when they have less than a month to live. Palliative care services are often underutilized due to a lack of a physician's inability to know who is eligible for palliative care, the gap of knowledge in palliative care, and a lack of research into palliative care to create new advances. Palliative care is often mistaken for being reserved only for patients who are terminally ill. Dr. Cohen, director of the Renal Palliative Care Initiative, suggests that oftentimes healthcare providers assume that palliative care refers only to end-of-life care. He suggests that palliative care be provided for patients who continue on in dialysis to help alleviate their pain and symptoms. Research into the field of palliative care is limited due to a smaller number of researchers focused on palliative care and their inability to receive funding because it is such a new field. In summary, most of the research completed so far shows that most patients do not have enough knowledge and information to make appropriate decisions about their end-of-life care. The research also implies that physicians need to be trained in what hospice provides, how palliative care can be used effectively, and how to discuss end-of-life care with their patients. Improved research can create advances in palliative care if more researchers get involved and more funding is invested. When my grandmother was diagnosed with incurable cancer, hospice came in and provided services that we desperately needed at the time. My grandmother was able to make decisions about her end-of-life care and able to convey what she wanted in between her physician and her family members. Patients who consider physician-assisted suicide need to be educated about the alternatives available to them. Educating patients about the right to stop life-saving treatments and receive palliative care might change how they view physician-assisted suicide. Physician-assisted suicide should not be considered until hospice and palliative care are adequately explained and offered to both terminally and chronically ill patients. That concludes my presentation. Does anybody have any questions?
Who pays for hospice services?
Medicare, Medicaid, TRICARE, and most private insurance companies pay.
What kind of services does hospice provide?
Hospice provides a wide range of services. Services include but are not limited to pain management, psychological counseling, emotional support, drugs, medical supplies, equipment, training families to care for their family members, and also transferring family members to patients to short-term care when their families can no longer care for them. Bereavement counseling is also made available for the family members up to 1 year after the patient has died.